Okay, welcome everyone to this webinar. We're going to wait another couple of minutes to make sure that everyone's here, and then we start.
Sounds good, David.
Just going through the list, see who I recognize. Christoph Anna, is that the Christoph that I think it is? That'd be amazing. Welcome. Okay, well, we give it another minute. Maybe in the meantime, if everyone wants to write in the chat what their profession or background is, clinician, academic, what kind of specialty, it'd be interesting just to see who we're talking to. And also to test the chat, whether you can put it stuff.
I've also just noticed, David, that we have to allow, when it comes to questions, verbal questions, we'll have to just click on allow to talk to allow people to do that. It looks like everybody's muted essentially at the moment.
Yeah, we can do that if we...
Yeah, we don't need to do it at the moment, but at the end.
Yeah. Okay. What do you say, David? Should we go? Yeah. Okay. And this is going to be recorded anyway. And the most exciting talk is last anyway, so everyone can catch up. Good. It's my pleasure to welcome you to a British Pain Society webinar on the topic of placebo-controlled trials in surgical interventions, which Professor David Beard is going to talk about, and in physical and psychological intervention trials. Thank you to the Society as well for organizing this. And we're just going to start off with a couple of words about ourselves. And I'm going to invite Professor David Beard to just introduce himself, please.
Many thanks, David. So yes, just to give you a brief introduction, I'm David Beard, Professor of Surgical and Complex Interventions Trial Programme at the University of Sydney, but predominantly the Director of one of the Royal College of Surgeons Surgical Trials units in Oxford, in the UK. And I've got one of the Royal College of Surgeons chairs in surgical trials, which is also out of Oxford. As a background, I'm actually a physiotherapist. Many years ago, I've been practicing up till relatively recently, but I've just stopped that now. But I have a background in the knee, particularly in the musculoskeletal world, and have a portfolio of numerous trials, both in the unit and as chief investigator, and some of them have been placebo-controlled studies, which I've got a particular interest in, and hopefully share some of that with you today.
Amazing. An absolute world expert on placebo-controlled surgical trials, and very influential on the work that I'm going to present to you in a second. Before I forget, the admin of the webinar is going to be such that that I'll speak first, and then Professor David Beard, and we're going to have questions afterwards. But we invite people to put their questions in the chat as we go along. We try and moderate that afterwards. We're going to aim for about an hour's session. So myself, I am David, sharing my screen as well. And I'm originally by clinical training and an osteopath trained in the UK, and I've graduated with a PhD from Imperial College last summer, which was on the topic of clinical trials in physical and non-pharmacological pain interventions. And one of the focus areas was the question of how placebo-controlled trials can be designed in that context. I still work partly at the University College of Osteopathy as a postdoctoral researcher, and at Imperial College London in the pain research group of Professor Andrew Rice. I think that's enough in terms of background, so let's get started. Just a couple of conflict of interest declarations, nothing major. If anything, I've got an interest in the good standing of the non-pharmacological professions due to my own clinical and teaching background, and I'd like to acknowledge research funding from various sources as listed here. What I'm going to be talking about is a sort of mechanistic background. Why do we need these kind of trials at all? What are we trying to control for in them, and how do they differ from other types of trials? And then once we've understood the phenomenon, namely the placebo effect and expectancy effects that we're trying to control for, we're going to look into what that means for the design and conduct and the interpretation of clinical trials, specifically efficacy trials, which I'll define in a second. I'd like to step back and start by getting you to reflect on these kind of physical and psychological interventions, which is an umbrella term for things like manual therapies, talking interventions, psychological therapies, exercise interventions, but it could also involve needle, acupuncture-based interventions, devices, nutrition, and some self-management approaches like relaxation, for example. And I argue that what they have in common is that they are pretty individualistic. They can be highly interactive, which is one of the differences to surgery, as we find out later, and that poses a particular challenge for trial design. They're complex, meaning that they involve multiple steps, often multiple techniques, multiple appointments. So sometimes you would see your practitioner repeatedly. You go into your yoga studio at regular intervals. There are elements that are relatively ritualistic, just meaning that they are out of the ordinary, that they have some kind of meaning conveyed by them, and that they are repetitive. They are often talking to many senses of the person. If you put yourself into the position of a patient, if you've ever experienced any of those, it's not just touch and manual therapy. It's not just feeling your own body in yoga. There's a lot of sensory input there. And often they are advocated towards, sold based on some mechanistic rationales and reasons. So they come with inherent meaning. Often we go to them because of someone who's recommended that. They can be quite expensive if we pay for them ourselves, often site specific. So what that means is that they are textually rich, and as I've tried to outline, they can be quite meaningful to the person. And that leads us over swiftly to the topic of the placebo effect and placebo mechanisms, which is also being called the meaning response by Dan Merman in 2002. And in the same year, a placebo researcher from Aarhus, Lena Vase, described that it's probably the subject's perception, so how they receive and perceive the placebo agent, that seems to be central to the amount of benefit that they get from a placebo treatment. And we now know that this is mainly mediated by expectations that form around treatments and by conditioning and learning effects. If you think of Pavlov's dogs, that can be replicated, very similar mechanisms in the placebo world, where this contextually rich experience, not the pharmacological ingredient itself, creates a learned response, a physiological response. Before we go into that any deeper, I want to take a second to reflect on the different kinds of questions we can ask in research, but also in clinical practice, and just point out that we're mainly talking about these trials that are usually called placebo-controlled trials or efficacy-focused trials, which ask questions around whether an intervention works better than these placebo effects or whether they work in ideal circumstances. So we're talking about highly controlled trials that aim to distill out any kind of benefit that there may be beyond those placebo expectancy and learning mechanisms. There are other very important questions, such as how does something work, which can be asked in some way in these trials as well, but more often mechanistic experiments where you're trying to measure physiological responses and modify parts of the treatment. And then there are more what you call real-world relevant questions, such as, is this treatment working when I roll it out at large scale in a particular heterogeneous setting, groups of patients that aren't always very similar, in particular in different settings, and also whether a treatment works better than another treatment. So that's a very clinical question to ask, and there are pragmatic and comparative effectiveness trials that ask that. They are important, they complement these efficacy trials, but that's not what we're talking about today. If you're interested more in the pragmatic end of that spectrum, I refer you to one of the publications I was involved with here. Looking back at the question of is something more effective than the placebo effect itself, we have issues there in the physical and psychological intervention world that evolve around the lack of trials in the first place. There aren't that many efficacy-focused trials. And if there are some, then they are often of a low quality. And what's often criticized is blinding. So whether you can conceal from patients the knowledge in which group they are in, whether they get the test treatment or that control intervention that aims to control for placebo effects. And those design methods around how those control interventions are developed and implemented is often something that might undermine the quality, the validity of the trial, leading to results that we can't really interpret well or put our trust in. And the basic issue here is that that principle of a placebo-controlled trial where you have a drug and another pill that looks exactly the same but lacks this pharmacological ingredient. That principle is very straightforward in drug trials, and that's where it's mainly implemented in research traditionally. But how do you transfer that principle to something like manual-therapy, talking therapies, exercise therapies? And what people do is often resort to quite dissimilar solutions. So you could use an ultrasound machine that you switch off, or shockwave device that you turn off, and you tell the patient that's switched on. So the hope would be that they get a similar expectation of benefit and therefore similar placebo effects than in the active arm, and then you can compare those two. But there are some issues with these dissimilar control interventions, as I'll show you in a second. With this efficacy problem in mind, we set out about 4 or 5 years ago now to develop guidance for control interventions in those efficacy and mechanistic trials. A couple of definitions here. I've used those terms already. The placebo and nocebo effect, they refer to changes that are specifically attributable to those placebo and nocebo mechanisms, so these learning and expectancy mechanisms. And these mechanisms can be shaped, for example, by verbal instruction, by situational cues that affect those treatment expectancies. So these context and meaning factors that we started off talking about. And that's distinguishing placebo effects from the so-called placebo response, which are any health changes that result after the administration of an inactive treatment. And that includes not just those expectancy mechanisms, but also natural changes in your symptoms, as well as statistical phenomena. And here's a figure illustrating that. If you have a study where some people do not get any treatment, the no treatment arm, some get an inactive substance, the placebo, or an inactive treatment supposedly, and others get an active treatment. You see those differences here. People who don't get anything also get some improvement through those natural history and regression effects. The people who get the additional context, so the placebo, get an extra effect, and that's the placebo effect. And together, those two are the placebo response. What you're really interested in efficacy trials is seeing whether the active treatment, that net benefit, is bigger than the placebo benefit from placebo, so the placebo effect. That leads us to the next fundamental concept in these studies, which is blinding. And blinding means that you're preventing people from knowing whether they're in the test treatment, so whether they get the active drug in a drug trial, or whether they're in the placebo arm. I'm only referring to participant blinding. You can obviously conceal that knowledge from other stakeholders in a trial as well. And let's, for this here, talk first of all about participants. There are some challenges with that. One is that we don't, in many of those physical and psychological therapies, really work how they have their effects, if they have any. So if there are particular mechanisms, and often it's multiple mechanisms that are hypothesized to be important. And sometimes it's hard to identify that one component that you're trying to take out to render one treatment an ineffective or placebo treatment. So you need to specify what the component of interest is, the effect of which you're trying to study in those trials. And that can be hard because sometimes we don't have a good knowledge of that. The provider plays a really important role. Many of those treatments rely a lot on that therapeutic relationship, and that can become a challenge in clinical trials where it's not about enhancing that relationship. It's about trying to get it, get comparable results between different groups. And then, as you will appreciate, those control interventions are rarely as inert as a sugar pill. So inert meaning not having any specific effects. In fact, in the control treatments in some trials might be the test treatment in another. An example is a soft touch control intervention in a manuotherapy trial, or education in a psychological intervention trial used as a control intervention. In some other studies, someone might investigate the effects of therapeutic touch or of education in itself. So it's conceptually really, really tricky and difficult to untangle. Now, we could say maybe blinding isn't that important, and there are certainly open label placebos where people know that they're getting a placebo, and at the moment the thinking is that they get a benefit as well. So maybe the knowledge of it is not as important, or there are some studies that would suggest otherwise. This is an influential meta-analysis a while ago suggesting that trials where participants are not blinded generally overestimate treatment effects. So they tend to show lower placebo effects potentially, and therefore that difference is larger. But that's debated. There are studies that show the opposite, or they are less conclusive. And this is probably the meta-analysis or the review at the moment that's the sort of go-to source on that question. A review of 47 other meta-epidemiological studies, so a large review of reviews, and that concludes that there is an absence of high certainty evidence, but we should be cautious about those trials that are not blinded. So they suggest to err on the side of caution, saying it's probably a good idea to achieve blinding or attempt for blinding in those studies. And I would add to that that it's not just about the placebo, the sort of knowledge concealment, but it's also about matching those contextual factors. We're going to look at that as a concept in a second. Further on, one of the issues, if you look at trying to do a meta-analysis of manuotherapy trials, and you have studies that use a switched-off ultrasound device as a control, and others use soft touch, or some use a simulated maneuver as a control intervention, it really poses a problem whether you can lump them all together and say they are all efficacy trials and we can compare them with one another. So if we are able to standardize that, at least we're going to end up with a body of literature that we can compare and that we can work with and draw conclusions on. Now, here's another problem. Maybe placebo effects aren't actually that big. So yeah, maybe blinding matters, but maybe it's so minimal that we can, or maybe it's so always the same that we can just cancel it out, and it doesn't really influence our interpretations. We've looked at 3-arm studies where we were able to do exactly that comparison between a no treatment arm and a placebo or a control intervention arm, trying to quantify those placebo effects. And what you see here is both colors here compared to a no treatment control group. So in the control intervention arms, the placebo arms, the blue bit That's what you typically call a small benefit from those contextual factors. And the benefit from those treatments that were studied in these 17 RCTs was larger, but the proportion of the placebo effect was over a third. There's a considerable contribution there, certainly. And without going into any further detail, what we also found was that the way those control interventions were designed, for example, whether they used manual hands-on controls versus switched off devices, made a big difference for the magnitude of the placebo effect that they found. So it really suggests that the design of the control intervention influences study outcomes. Another really good argument for standardization. I think I'm going to skip that just in the interest of time. If you're working therapeutically and you're interested in the evil twin of placebo effects, I would invite you to look at this study here. This is more of an opinion paper here in Musculoskeletal Science and Practice, inviting you to reflect on the negative consequences potentially of what you do. But let's move on to the question of, okay, how does that all apply to clinical trials? And what we did here was another systematic review where we looked at the current state of affairs of those studies, describing how those control interventions are designed, but also trying to quantify whether they influence study outcomes. You don't need to understand the detail here, but what we looked at specifically was whether control interventions and test interventions resembled one another. And we did that across 25 different features. So for example, whether the duration of the treatment was the same in both of these arms, or whether what people were talking about, thematic content of the session, was the same. And what you found, what you see is that some of these sort of more structural issues, like how long and how many treatments and how is it delivered in person or groups, these tend to be very similar. So further towards the right means that these factors were similar between control intervention and between study arms, and the colors also show you that that was the same between spinal manipulation trials, craniosacral therapy trials, physio exercise-based trials, and psychological interventions. If you then go further down in that list, you see much more variable, much less similar control interventions for some features, and also big differences between the different types of therapies. So a big lack of standardization here in those 200 studies, almost 198 studies that we looked at. We also assessed whether people said why they designed the control intervention the way they did, and very non-surprisingly, people often didn't. Things like quality assurance, such as asking participants afterwards whether they thought they were in the treatment arm or in the control intervention arm, was also often not performed. And we performed a meta-regression analysis, without going into detail there, that showed that the level of similarity and dissimilarity had an influence on the treatment effects, on the magnitude of the results that you saw in those studies. So we've clearly described the problem now in those systematic reviews, and then we fed that information into a Delphi study, which aims at coming up with recommendations on how to do things better. We also involved several people living with pain to ask their views on how that would affect them as potential trial participants, and then had workshops with those experts and patient partners, and coming up with this so-called COPS statement, which is now has been published earlier last year, and hopefully sets the standards for both the development, the implementation, but also the reporting. So how people write about what they did in the study for those control interventions in efficacy and mechanistic trials in these particular types of therapies. And that's the COPS statement, just showing you the author list here, mainly to acknowledge their contributions and thank them for their hard work and for seeing this through with me. This involved both experts from clinical trials, so people who've done those clinical studies, but also people who study the placebo effect, which was important because they obviously know how to, they know a lot about the phenomenon, the effect that we're trying to control for in these studies. We went through 3 questionnaire rounds where they were anonymous and had to rate different recommendations, ended up with quite a long list of things that should be implemented and should be considered. And that all was then formulated as the COP statement. Now we're going to go through some of those items here, but apart from the actual conceptual development and the conduct in a trial for those control interventions, we also expanded on a reporting checklist. So that's now on the Equator network, which is your go-to library for if you write a scientific article of any kind, you find often a reporting guideline for this particular method. So that's now adopted by Equator. And we also made some comments about how to involve patients and other stakeholders, ideally from very, very early on in the development of a study, and also about terminology. So one of the things we suggest is to avoid terms like placebo control and sham control, because they often misunderstood, mean different things to different people, and they can be quite negatively connotated. You know, if you sign up for a study in which you know you've got 50% chance of getting into a sham group, that's not very confidence inspiring, and might create expectations in themselves. So the recommendation there is to describe what you set out to do, and that you design a control intervention that takes out a particular part, removes a particular part of the treatment that you're studying, to study that. And in order to do that, you need to clearly define beforehand what the objectives are of your control intervention, whether it's to achieve blinding or to balance contextual factors. You need to relate that to your research question. What are you studying there? You need to define the mechanisms. Even if it's a complex intervention, you do have the need and should be defining what it is that you hope to isolate and to study. And at the same time, you need to specify which parts of the treatment you think are acting on those mechanisms. So if you say you're aiming to achieve muscle relaxation, which part of your physio intervention is it that aims at reducing muscle tension, for example? And then based on this conceptual thinking, for which you need to go into the literature, talk to stakeholders, you can design a control intervention that resembles the test intervention as much as possible, replicates as many components as possible, apart from the component in the effects of which you're interested in. Now, practically, one thing we found as well with those systematic reviews is that people don't really report about testing this before they run a big study with those control interventions. And that's quite surprising, but it really also is a missed opportunity to make sure that this control intervention can actually do what you want it to do, whether it can blind participants, whether it leads to similar expectations of benefits. And like I said earlier, providers are often an integral part of those treatments. They can't be blinded in many, many of those cases. You can't deliver a control intervention with your hands or as a psychologist and not know about it, or very rarely at least. So what we need to do is recognize this as an issue and work with providers to recognize that in a clinical trial, they have a different responsibility, not just to their patients, but also to the integrity of the study and what that means for their behavior, for matching their behavior between study arms as well. Same applies to other staff involved in a clinical study. Yeah, these are the main points for the development. And then during the trial, there are some quality criteria that you can monitor whether providers deliver the intervention and the control intervention as it should be done, whether participants adhere to that, and then also the expectations that arise from that. They should at least be evaluated once. It's not quite clear when the best time point is to do that. Certainly a bit more work there if it is needed. And then a really important and strong recommendation: if blinding is your objective, if you're trying to avoid people or prevent people from knowing what kind of treatment they're getting, you need to ask them at some point to make a guess and then interpret that and take that into consideration with your results interpretation. This is a very brief overview of the content of this statement. If you're reading clinical trials regularly, if you're interested in the sort of mechanistic thinking behind them, but in particular, if you're involved in clinical studies, I'd really invite you to have a read of that statement. It's only been published last year, so we're really trying to gather a lot of information about how this works out in clinical practice, in research practice. And that's what we're collecting over the next few years. And I just want to finish with a few reflections, definitely saying that these clinical trials are still very challenging, but at least we now have a consensus-based, evidence-based guidance on how to do things better and how to standardize it. There will be more trust and more comparability of trials from that, from following the COP statement, hopefully. And we do need to still acknowledge differences between drug trials and non-pharmacological trials. They aren't the same. They might have to be interpreted differently, which may have an effect on how you can compare them for clinical trials, clinical guideline formulation, etc. Another area where definitely some work needs to be done. Maybe you have some ideas as well on how that plays out, what challenges could be, what implications might be for you, for your patients, for your research or clinical practice. But I'm going to leave it here for today. Just want to invite you to scan this this link here. I'll also put the link in the chat in a second, just to get some feedback. I'm on a little bit of a dissemination tour of that COP statement, so it's good to get some feedback. And I also want to thank my supervisors and everyone who's seen this through, also the members of the systematic reviews that we were conducting. That wouldn't have been possible without quite a few volunteers there, and the experts on the COP statement, the impact group. Yeah, thank you very much. And with that, I'm going to stop sharing my screen, go back into the webinar, and invite Professor Beard. We're gonna, I'm definitely gonna share the link of the article. You can find that at the end of the feedback form, which is a smart move. And I'm going to hand over to Professor David Beard. We're going to have questions afterwards and taking them together.
That's great. Thank you very much indeed, David, for that, which is a really good introduction and covered a lot of ground, actually. So you're going to see some of the concepts and things not repeated, perhaps, but perhaps put in a slightly different way. Let me just share my screen to start with. Let's hope we can see that. So that's a great kickoff and good coverage, as I've said. Same topic, but I'm actually going to go about it slightly differently. We're talking about surgery, so it's a different intervention. And I'm going to sort of talk about the concepts to start with and then go into the good and the bad of these things. Sometimes it's not all great. There are problems, and there's sometimes more problems or issues with these more complex designs than you expect. And you just need to be aware of them if you're going to set up some of those sorts of studies. I've gone through my introduction, so I don't need to do that. I just noticed, though, that I did have this radar initiative up on there as one of my salutations, and that's about robotic and digital surgery. I'm involved with some trials with robots. I thought it's got nothing to do with this, but I'm actually quite mindful thinking about it. It's probably one of the highest levels of placebo, as we'll see as we go through. It's exactly what we're talking about. Okay, let's disclosures, nothing of this which affects this talk at all, and all pretty much grants and institutional grant based, so there's nothing there to give. Now, the outline, what I'm going to do is just talk about the need for placebo control. David's already covered a lot of that, so I'll skip through some things quite quickly. The concepts of surgical placebo control, which are slightly different, and then probably spend most of the time talking about one particular study, Seesaw, which I was chief investigator with a colleague of mine, Andy Carr, and then there's other studies as well, one particularly in Australia, which I'm involved in with spinal fusion with Manuel Ferreira. And I'm going to talk about the good, as I said, the bad, or the difficult, maybe not bad, but more difficult, challenging, and where we go from there. I am recovering from a chest infection, so I'm almost bound to cough at some stage, so bear with me, and I may well drink a little bit as we go through. So let's give it some backdrop and some context for this. Any kind of treatment that we introduce as practitioners should be evaluated. We should know whether there's any benefit for it or not. And, you know, people have been aware of that for some years. And in the pharmaceutical world, it's established. So it takes a lot of money and a lot of effort to get a drug to market by showing that it's got some value and works. In addition, which is really important, that it's safe in the first place. We've been in surgery a little bit Luddite in that world for lots of reasons. It's a complex intervention, and there's lots of reasons why it is more difficult to evaluate, but perhaps not been evaluated anywhere near as well as drugs and pharmaceuticals. And that's attracted, well, there's a couple of things happen. You've seen some nasty headlines like this with some surgical procedures, with the transvaginal mesh, with breast implants, with hip replacements. And they're not very nice headlines, and we would like to try and eradicate them, really. And a few years ago, it's probably about 10 or 15 now, is it? No, it's longer than that, 96. So Richard Horton encouraged the surgical community, really, with some rather spicy words about saying that surgical research was comic opera and needed to pull its socks up. And it did, and it has done. And the Royal College here in the UK and other areas, and particularly in Scandinavia, have done a great job at changing that. And placebo trials are one of the components of getting to that place. And we've heard, from Baroness Cumberledge, there's a report out now which says that we should probably look at things in a bit more detail. It's not been in a great place with devices and surgery in the past, but it's made some really great gains with some of the initiatives that have happened with the Royal College and elsewhere. But we need to do it. Why do we need to do it? Well, we need to generate this evidence, which David has already talked about, and that's for decision making. And it's for both patients and surgeons, that decision making which goes on, and whether you should have the treatment or not, or the surgery, you need to have some evidence to show that it works. So we put that one at the third: confirm medical interventions are safe and provide a benefit. Safe, important, but also that they're useful, and you're not doing something which has got no benefit. And then secondary, which some people tend to want to put as the first one, which I tend to pull back on a little bit, is to restrict ineffective interventions. Yes, of course, we need to make sure in this day and age of value for money that we're not offering interventions which have got no value. And also if they're just potentially risky without offering any value as well. And I've got a runaway train there. So what happens is sometimes in medicine is that things take off, they get accepted very quickly, and then it's usually failures or problems further down the line, which we have to address. And rather than getting to that point, rather than it being a runaway train, one way of doing it is to look at things early on with the designs that we're going to talk about now, to make sure that we've got beneficial treatment and safe treatment. And along the way, you can do a couple of other things. You can find out a mechanism, you can see what works better than other things. And there's a lot of questions that you can ask, but it's all about uncertainty, and it's all about generating evidence to make sure that we make the right decisions over surgery. And it is important because you can see the stats there. A third of all hospital admissions for surgical procedures, and that's in the UK, and there'll be overseas listeners here, but that's £10 million in the UK per annum, and it's 10 billion per annum in the UK of that. So we're talking about an awful lot of money spent on surgical procedures. So if you want to go and evaluate things and look at things, then those of you who've done clinical trials and in that area will know and be really familiar with this PICO framework, whereby we look at the population, the intervention, the comparison and the outcome. And what placebo is about, and it comes to population, you'll see later on, but it's predominantly about what comparator you use in your study, comparing the treatment against something else. And there's various options in that. David's touched on it, and I'll come straight into that as well. We're looking at it for safety, of course, but predominantly effectiveness and if there's a mechanism along the way. So when your fresh-faced surgeon comes along and wants to ask a surgical question and test a hypothesis, see whether something works or not, we point them straight to the PICO and to set this whole framework in place. The comparator that you pick is really important, and it needs to answer your question. And again, David's already touched on this, but it's really important that you choose the right comparator that answers the question that you're interested in, not just because it's sexy. Don't just do placebo-controlled trial because it's the thing to do. We don't just do a comparison trial against another treatment because it's easy to do. It has to answer the question which is important. So just bear that in mind if you are starting out and looking at things in terms of evaluation. And this is a slide which I'm very fond of, but it's saying the same sort of thing that David has already covered in a way. It's what question do you want to answer? Is it on the left-hand side there, if you're looking at the screen, fundamental efficacy and effectiveness? Does it work at all? Or do you want to look at something a bit more relative in terms of relative benefit or comparison with other treatments, treatment comparison efficacy? And you need to really think about that when you're asking these questions, because they do answer and ask very different things. The best treatment, of course, we can compare that, but they might be the best treatment out of two poor ones, or it might be that we have two treatments that are very good and there's not much between them, but it doesn't tell you the relative merit against not doing anything at all, or whether you should do it against something which is perhaps masked by bias, like we do with placebo. So the black and the green there, you've got two separate questions. One is, does it work in the first place? And we should probably do that, right, for every single intervention that we have in the first place. You either have surgery or the complex intervention against nothing at all, and you see whether it works or not. That should be base one, in my opinion, every time. It isn't, unfortunately, because things get adopted and get used straight away, and then ethically we say we can't remove them. But I'm always suspicious about something that we can't remove when we've never really shown that it works or not. And then you can move on and say, how does it work? And is it a bit more complicated than that, because the treatment has parts to it which may add to the benefit, but we need to understand it. And that's where placebo comes in. It becomes a very strong model and design, because it takes account of some of the things which occur with treatment benefit outside what we'll call as the critical therapeutic element. And you'll see that a bit later on. This schema here, you can see those arrows. So as you go to sort of that side, the red side, and towards best treatment and comparison efficacy, patients like that. And because you're having a treatment of some kind, it's easier to administer as a trial, it's easier to administer as a study. And so there's increasing patient acceptance. If you go the other way, it's more complicated and it's more difficult to get people engaged with that. And you'll see a little bit later with some of the examples we've got. So just bear that in mind, that when you're thinking about what question you want to answer, one is a bit more difficult than the other, but both have their place. So as we've said, if this really for placebo is this area of fundamental efficacy or efficacy, whichever college you want to have, and you choose it when the placebo effect of the treatment is likely to be high, because you want to account for it. And I'm coming from an evaluation world here, not just a sort of phenomena interest in placebo. This is about how we account for the placebo effect with evaluation. And then the second reason that you might do it is if you've got ideally you'd have a no treatment arm at all, as a first base, as I've already said. But if that's not an option ethically, or for any reason that patients won't accept it, then you might consider a placebo design. What does it offer? Well, it offers these two things. Dave's already talked about bias, and bias is a huge thing in research and trials, and we control for that unwanted bias. So the bias of just undergoing surgery, and we'll talk about that in a second, or a complex intervention, you can account for that and take it out of the equation, which is really important. We'll talk about whether that surgeons will accept that and whether they think there is a placebo effect. But and you might think surgery can't be, there's not much with placebo effect with surgery, but you'd be very surprised that there is. And then secondly, mechanistically, we want to understand the phenomenon by which any benefit occurs. And this quantification, again, Dave's talked about that, of the placebo effect. We can get to that point potentially with some of these designs. If either of those is a yes, then we want to do a placebo-controlled trial. And in surgery. So it's not quite as easy as a blue and a red pill, but it's still achievable. So we want to take account of the placebo effect, and we want to know what's going on with the intervention as well. You might say, oh, what are the components of placebo intervention with surgery? Do they really apply? And they do, and they're very much the same as any other area. And they're enhanced in certain parts as well. So if we look at this is taken from the Aspire guidelines, so you'll see about that later, but there's various domains which that comes in. The treatment characteristics, just undergoing the treatment, which is very similar to the real treatment. So just being cut, for instance, or opened up, and the feeling of being cut will have an effect on patients and think that they're having some form of real treatment. The setting that you put it in, going to an operating theatre, the whole rigmarole of being put under anaesthetic, the whole process whereby you're having this surgery or intervention also contributes to that feeling. The clinician characteristics, so the high status of the practitioner, the amount of training they've done, it's a very difficult thing to get to that point, also adds to the whole placebo effect of surgery. And then, the patient's characteristics. So they might have previous experience of undergoing it, or it might be a friend of theirs that's had it, and they may overlay from that side of things. And then lastly, just the convincing nature of clinicians. So an extensive or very positive interaction with the patient that may influence their level of response as well. And clinicians, if you are a clinician like myself, are very aware of that. And you can achieve quite great benefits by just an approach or how you shape things or how you position things with patients, and that shouldn't be forgotten. But it's all part of the package of the placebo effect within surgery, and you need to account for that, and particularly in operations and surgeries where the critical element may not be as strong as we think it is. And let's talk about that just for a second. So again, Dave's covered this off, but it's just a different schema and showing it in a different way. What we've got here, and it's been really well reported by Carolina Waterliska, who used to work with us here and is still doing some placebo work, and she's laced throughout this presentation, actually. But what we've got is these two improvement profiles, if you like, or benefit profiles, one in surgery and one in placebo. And if there were two arms, for instance. But what you're looking at, if you break it down, is that the pale blue here are all the non-specific effects. So when you do some surgery, there's lots of things that go on, from parting the tissues to cutting to an inflammatory response to whatever. In both arms, that will occur. They're non-specific to the actual operation per se. Then there's going to be a placebo effect. We don't know how big that is, but you can probably measure it if you want to. And it'll be different for different people and in different circumstances. And then kind of the important thing, the active ingredient, if you like, of what would be in a drug is what we call the critical surgical element, the bit of the surgery which we think is doing the good, doing the benefit. So it might be the removal of something, it might be the adjustment of something, it might be the separation of something, it might be the addition of something, but that's the piece, that's the active ingredient, that's the piece of surgery which the surgeons are doing it for to be able to achieve the benefit, with the backdrop of all this that's going on in the non-specific area. And really, if you are a surgeon and doing that sort of thing, you tend to believe in this. So what you want to think of is that you're doing something which makes a big change. So what you really want to happen is this critical surgical element to be rather large compared with the rest of the non-specific and the placebo effects. If it isn't, then you start to question, and some of the Scandinavians will do a two-arm study to say that if you don't have that critical surgical element and it doesn't show any benefit, then we should question the treatment. If you're a bit more holistic, and you believe in the other effects and you're not too worried about mechanism, then this package can still give you benefit, and you might want to do that. I mean, you get into the realms then of saying, should we pay for placebo care, or should we pay for treatment that we don't really understand how it works? Some will say yes, and some will say no. I'm not going to get into that today. But in terms of breaking it down and understanding the mechanism and the design, what we're after is separating out the critical surgical element and making sure that we account for the placebo effect within surgery. How do surgeons feel about it? Well, they quite like it in the main. They appreciate it. Again, a paper by Carolina. They think there's a therapeutic benefit of 77%. We've surveyed a group of surgeons, and they were a bit uncomfortable about deception, because there's some deceptive element to it when you first present some of these studies, because the patient doesn't know what they're in. And people will argue that that's not a very comfortable position for patients, that they don't know whether they're having the real treatment or not. But you have to be in that position to be able to keep it blinded, as we've heard already. So that does undermine, or can potentially undermine, patient-surgeon trust. So people were a little bit mindful over that. So in the main, happy, but there are some aspects around it which can be queried, and we haven't really sorted out fully yet. We're getting better, as you'll see later on. So there's trials around, and my background is mainly orthopedics, plastics, and things like that. So they tend to be in those sorts of disciplines. Rachel Bookbinder from Melbourne did a very good study down in Australia on vertebroplasty for painful osteoporotic vertebral fractures, which is a landmark study in the New England Journal. And we've got one ongoing at the moment with Manuel Ferreira in Sydney, which is spinal fusion. And also in Sydney, Ian Harris has written an awful lot about placebo and surgery. And we completed the Seesaw study, which was followed up by FIMPACT, and the Scandinavian group did a very similar study as well. And I'll talk to you about Seesaw, which I was the chief investigator of with Andy Carr and the team. So let's just talk about, oops, sorry, flicked. Let's just talk about Seesaw, which is a project, and it's the old Arthritis Research UK. It's now Versus Arthritis, but it was a charitable funded project and study, and you can see that it was with my colleague, the shoulder surgeon, Andrew Carr, and the team there below. And what we were asking was, we called it Seesaw, can shoulder arthroscopy work? We'd probably change the name now. But it is arthroscopic subacromial decompression. That's a surgical procedure, and I'll tell you what it is in a second. More effective than arthroscopy only or no treatment. So 3 groups, a question to find out whether it's worthwhile actually putting a scope in and taking some tissue out of the shoulder. Just to give you a background of that, the shoulders are a huge amount of pain with subacromial pain. And if you look into people's shoulders on imaging and even on arthroscopy, but you can see that they have a bit of tissue, which looks like it impinges and can cause the pain. And the space is reduced. And it makes an awful lot of scientific sense, and it's rationally very sound to say, if we go in with an arthroscope, take a bit of tissue off, does that help? And it'll help free the arm, increase the space here, and you should reduce the pain. So all very sensible from a theoretical point of view. But there's a bit of a gripe in the background of all of this. I wasn't involved in the shoulder particularly, just as a methodologist and a trialist, and it piqued my interest. But Andy Carr, who was a clinician, started to notice that not everybody got better, and also that we started to look at some of the incidents of the surgery. And there's this huge exponential growth from 2000 to 2010 in the incidence of doing this operation, 7-fold increase, and without any solid research or evidence behind it. So, and you can see the variation in the UK, which happened as a result of that. It was published by Andy Judge. But what it says to you is that that's fine. This plot might well be great as long as we can show that this particular procedure works, and is it sensible to do so. So our objective and research questions were to compare the shoulder surgery with and without this surgical element, this critical surgical element, to sort of take away the bone and tissue or not, and take into account of the placebo effect of surgery, because people undergoing surgery wanted to get better. They were having a scope in, everything was happening completely normally as a surgery, but we just weren't taking away the tissue. So it's a placebo intervention, and I'm cautious with that language. So it's not sham, and we'll talk about sham a bit later. It's an uncomfortable word for patients, and it means something different. It's where it's a complete pretend operation. We're not talking about that. We're talking about an intervention which takes account of the placebo effect. And we wanted to know as well whether surgery in general, forget how it was getting there, did that work for the patient, the effectiveness of a surgical intervention or not. So 2 questions, and can be answered in the same design, which is really useful. So it does it all. What we've got is the investigated treatment, the proper surgery. We've got a placebo intervention, which it takes account of the placebo effect. So you do everything that you would do in this ordinary surgery, but you don't take away the tissue, which we think is responsible for causing the pain. And then just to add a little bit of jam on the top, we do a natural history, a no treatment intervention, just to see what would happen if you didn't have either of the surgeries or anything at all. And that will give you an added piece of information, which I personally think is very important. And I like to do it. It makes it more complicated in terms of recruitment, but it gives you a lot more information. So here's the design. It's a double control design. You've got your control group, natural history, doing nothing, and you're comparing it overall to surgery. So you can answer that question, whether you take the tissue out or not. But the interesting one really on this sort of context and for this placebo talk is that this difference between the active treatment and the placebo-controlled treatment. Do you have to take the tissue away when you do exactly the same operation? We had 313 patients. There was a good spread of surgeons and centers. You can see the external validity was quite high, published the protocol. And we were just looking at pain, function, and cost effectiveness, and at 6 months and 1 year down the line. And this is the sort of money slide. This is the results of it. And you may or may not have seen it, but what we ended up seeing was that this is the arthroscopy only group, which is actually the placebo control group, if you like, the red one, at 6 months. And it's the mean Oxford shoulder score. It's a PROM that we were looking at, function and pain. We looked at 6 months, and then we looked at further down the line at 12 months. And compared with the actual surgery, the decompression, you can see there's very little difference between them. So the statement there that there's no difference between taking the tissue out and doing the arthroscopy by itself stands. You could say that they're both valuable because look, both of the plots are in an upward direction, getting benefit. The shoulder score goes up. But if you look at this no treatment group, that also does the same thing. And you end up in a bit of an argument, and we'll talk about with interpretation, whether this gap between the two has got any meaning at all. And that's a debatable fact, but overall, you would like to say that actually there's no difference between the placebo and the actual surgery, and there's not a great deal of difference between no treatment. So you come to this conclusion. You go, well, we've got no difference in the surgical troops. We've got the surgical groups. We've got minimal difference between surgery and no surgery. And we can come down quite reasonably that the surgery does not provide the benefit by the mechanism that we thought. And it's not a substantial, the benefit of surgery overall is not as substantial as hoped for. And you can only do that with the placebo-controlled design because you've taken account of everything. Now let's talk about some good and bad in all of that. That's the project and where we're at. Let's just skip through a couple of examples of where we're at with it. That's Lee Van Cleef, I think, from the good, the bad, and the ugly. So we're going to talk about operational design, conduct, interpretation, ethical issues. So the first thing that comes up when you ever talk about this, and Charles Vire, who's on our panel, who will aspire, talks about this very well, but it's the first thing that people say is it's unethical to expose patients to risk without the prospect of medical intervention. So you're doing something, you're doing placebo surgery. Theoretically, you know it doesn't really do any good. Why are you doing that? And that's a very reasonable position to take. And if you talk to the ethicists who are along that line and don't like a utilitarian approach, they will say that that's not a very good design to use. But it's probably the only way that we find out whether the surgery really works or not. So to be able to do that, you have to make sure that what you're doing in the placebo arm is not hurtful or harmful. And again, Carolina, we did a systematic review of all the placebo surgery at that time. It's a little bit dated now, but we've updated it. And the adverse events were minimal, and they're actually greater in the surgical group compared with the placebo. So patients in a placebo arm with the particular type of surgery, it tends to be minimally invasive, they are not under any real risk at the moment. We've said, you know, ethics-wise, you've got to accept that this is a utilitarian approach. It's the same with any research. It's looking and exploring things which may not have any advantage for a group of people for the better good of lots of other people. But if you don't agree with that, we're not quite at the stage yet of personalized research, but it may come in. And along those lines, you know, this is an average. You get an average at the end of the day on a trial, and it doesn't look at the individual benefit. And there will be patients in a trial which get better, and they are, unfortunate at the end, they are disregarded to some extent because the mass study consequence or conclusion is the one that predominates. So it's still the gold standard, the RCT, but we're working really hard at the moment to try and personalize things and not lose individual benefits and keep the evaluation rigorous. Not there yet. There's a few barbs in there as well with this, and we'll talk about it. The deception and consent is a bit awkward. The recruitment dialogue is difficult as well. And then sometimes the nomenclature for writing up changes. So we'll talk to the patient about one thing, and then by the time you write it up, it sounds a bit more sensational and in technical language. And that can be problematic also. And I think we've learned from that over the years. I'd certainly redo Seesaw in a slightly different way. But there's some issues with the pitch for this. You've got somebody who's going to go into a potential placebo-controlled trial, and you ask them, will you go into a trial? So you're going into a trial to see if the surgery or the operation that you're about is effective. And the very nature of sitting in front of a surgeon and thinking about that you're about to undergo surgery when the surgery itself has not been proven to be beneficial is problematic. And so that's difficult in itself, and it's also difficult for clinicians to sort of sit and do that and be involved in research with it, because there's a lot of belief surrounding these things. And then you add in placebo and say, we're actually going to do some, and for want of better words, pretend or incomplete surgery. It makes it even more difficult. But they can be done, and once people grasp it and understand what you're trying to do and the importance of it, then we haven't had a great deal of problem recruiting to them when they're done well. And we use a lot of qualitative support on that from the likes of Jenny Donovan's group and people who are involved with recruitment profiles. But you have to be careful. So this is work from Katie Gillies in Aberdeen along the same sorts of lines. It's done a really nice piece of work to say that you need to make sure that your patient information leaflets are really well described, the core content is explicit, and you're giving as much information as you can. You're not talking about sham, and consider the whole information across the trial timeline. This is where PPI is really important, and you have to engage with patients. I mean, it's not just lip service. And I think, again, we probably would do that better today if we were starting out with Seesaw as we did previously. The critical surgical element is difficult to find. It's sometimes, this is work by the Bristol group, they're excellent at it, Natalie Blanco and Jane Blaseby, with others, but you know, this critical surgical element doesn't always stand up. It might not exist. Does it happen in cancer? What's the bit that you actually do, which is really important? In emergency care, if you snap your leg, break your tibia, you need it putting back together. You can't really say that there's a part of the surgery which is the critical surgical element. You've got to put a piece of metal in there to fix the bone in something or along those lines. And that this is where it kind of falls down a little bit. So not every operation lends itself to a critical surgical element in the way that we've done it with Seesaw. And you know, you can look at the paper, the Ditto framework to sort of deconstruct and break down the elements of surgery is really important for that, because then you need to pull those out and identify what is going to be the placebo type of the operation and what is not. So lastly on this, to some extent, interpretation and implementation. It's never straightforward. So I just talked you through this graph already and said what it means to us, but you'll get arguments on it. So people will say, well, I'm not bothered in the end of the day. This surgery seems better than not doing anything at all. So why don't we use it? And it's a valid point. End of the day, it's 4 points on an Oxford shoulder score. It's inside the minimal clinical difference. And you've got to really question whether you'd want to stand and support that in court. Because to me, the lines are all just a little bit too close together to say that this operation is that valuable. That said, if I was remember, these are means. If I was one patient that I produced, I was up here somewhere, I was the one that produced a high level of benefit, that is lost in that plot, and that might have been very beneficial to me as an individual. We thought that done a study, great, high level thinking behind it, good design, rigor. We've got a procedure now without a mechanistic basis and with no clinically important benefit. It's really straightforward, job done. So clinicians will now say, we probably shouldn't do too much of this anymore, or we'll look at it a lot more closely. That was my hope, naively, but it didn't really happen like that. The goalpost changed. And what happens out there is that there's non-believers and objectors, and there's the commissioners get involved as well, and they want to remove the procedure without really thinking about what that's about, just because we've shown that it's not that effective. We have various societies objecting to it, and that can take its toll on implementation, because people will just say, I don't want to believe it, it doesn't suit my model, and therefore I'm not going to use it. But it does question whether we should run with evidence-based medicine if you do these sorts of studies and then don't believe it. But this is interesting. Those who seek the truth run with the risk of finding it. And Seesaw is a good example of that. I think most of us thought that it would show that the surgery was beneficial. And when it turned out that it was no better than placebo and much better than nothing at all, then you start to get a bit worried if you're doing lots of those operations. And particularly if you've got industry based upon it. So you have to be aware of that and have empathy towards that. This is not about throwing stones and breaking everything, but it's making sure that you get to a place with these sorts of studies that we offer the right treatment and there's some moderation where moderation is needed, like Cicero would say. So the good, just to finish on, so they're the kind of complications with it, the difficulties. And we've got Clint here with representing the good. What we've done is we've ended up getting more sophisticated, if you like, and really broken down some of the aspects of placebo, which we already talked through. We had a working party there sponsored by the NIHR MRC, which was great a few years ago, and published this paper on the ASPIRE guidelines. If you're going to do a placebo-controlled surgical study, you should definitely refer to this and look at it, because we've tried to sort of share with you all the problems that we've had trying to do these sorts of studies from an international group, and that's been very helpful to understand it. And we've come up with things, just as an example, like the critical surgical element. We're coming away from the word placebo. We're talking about intervention fidelity, and what you might have is this index procedure in terms of fidelity. It's the complete procedure. That's your standard treatment. You may have high, low, or medium fidelity, where the operation is close to the index procedure, or it has very few attributes of the index procedure. So you might just cut the skin and move the tissues a little bit. This high fidelity might be right the way through the operation, but you just don't do one thing. And then in the bottom there, there's a no surgery control with that. And we don't like to use sham anymore because it's not really helpful. And just as an allegory, I tend to use this. So the proper treatment is the full car without an engine, car without an engine and seats and a thing. It still looks like a car. And then a car which actually isn't a car but still looks like one at the end there, or different bites out of the apple. And then one thing that's happened with Seesaw, I just put this on at the end here because I've just been examining a thesis in Denmark, and I'm about to go over and do the bio, so I can't say too much about it. But we thought it was all about the comparison, but actually we showed that there was no difference. And one of the reasons that might not show any difference is because the population that we chose and sampled was very broad. And that may well be the case. And this piece of work, which I've just looked at, demonstrates that, again, the nomenclature and the descriptor for the pathology and the comorbidity which exists, the more you dilute that, the less likely you are to get an effect with a particular or specific operation. So you have to pick your patients carefully is the message. If we were to redo Seesaw, we might well find a different result if we define them a bit differently and we're a bit tighter. But at the time, this operation was being done with a very broad range of individuals, and as a pragmatic trialist, that's what we looked at. So we didn't do any harm, but actually there's always a place to go back and look at things again. So in summary, the placebo-controlled trial, it's an elegant, beautiful and powerful thing. It's like these sorts of things. It's like climbing Everest or Rolls-Royce or Rachmaninoff concept, but it is challenging and it does come at a cost. And if you want more detail and sort of the ASPIRE guidelines and things that's in this HTA report there, if you want to scan that, and it'll give you a bit more detail. So just to summarize, it's certainly needed in some respects to investigate surgery. It's a useful arrow to have in your quiver. But it's no good just going into it without an understanding. So why you're using a placebo and the understanding behind it is really important. And things like which I've just gone through, understanding those trip hazards and difficulties and how you navigate that. It's no park and all. It's quite a challenging sort of design and way to go. So you mustn't do it for the sake of it, and you must have this rationale for doing it. And it's not every surgery, as I've said before. There's particularly with the minimally invasive things, particularly with things which sort of take a bit of a trend, might be appropriate. You're not in the area of emergency care. You're not in the area probably of cancer, although you can still use that. But it's not predominantly in those sorts of domains. But when it's done well, it's a very powerful method, and I suggest that you have a look at it. This is just to show you the sort of people that we're involved with and help out with these. That's for Seesaw. But over the years, I've been helped out by a vast array of people, and if anybody's listening, you know who you are. But I thank you for that. Okay, I think we're just about up on time. We've probably overrun by about 5 minutes, actually. Sorry about that.
Yeah, perfect. Thank you so much for your talk, David. That was fascinating. Yeah. I'd invite people to ask questions. David, maybe we start off why people type their questions. You mentioned that the sort of provider allegiance, surgeons tend to believe what they do for a good reason. How do you get people to deliver placebo surgery in a trial?
So that's a good question. And what we've done is with various courses that we run on trials, and it's with younger trainee surgeons, is to introduce a concept of uncertainty with them. So most medical practitioners in the main are uncomfortable with uncertainty, and particularly surgeons who are decision makers and authoritative with that. So the last thing you want is somebody to cut you open and they're not sure whether to do it. But that's fine, and the skill and the ability to do that and the training and that is all still in place. But there may be some interventions. Just because you've learned something down the road by somebody else, it doesn't necessarily mean it is the most effective thing to do or as effective at all. So just introducing the concept of uncertainty to surgeons. Some will grasp it and some won't. And some will say, yeah, I'm happy to do that. I think we need to look at it. I think we need to be challenged. And then, my vision is that it's a bit like drugs in a way, that everything that everybody does has got some strong evidence behind it, and you're really comfortable with it. If not, you're slightly in a world of saying, it works in my hands or something like that, which I always think is a slightly dangerous world in social medicine. So introducing uncertainty is one thing, and just trying to engage with individuals that it's kind of an appropriate thing to do before, particularly with devices. You go down the road and you've got it wrong, it's going to come and bite you in the bum, and we want to try. But it's not undermining. It's the important thing is this is not about undermining anybody or anything. It's about learning and progression as we go forward. Just like the robotics, we don't really know whether it's it probably is, but it's probably a very useful thing. But it's good to put some numbers on it and evaluate.
Yeah, very different mindsets for academia versus clinical practice, especially if something's been in clinical practice for a long time, or if the whole profession is built around it, and the professional identity that comes with it can be quite tricky to. You see that, I think, with responses to clinical trials that don't go the way a certain profession would like them to have gone.
Yes.
You get those responses like, oh, that's not how, in my case, osteopathy is actually performed in the real world. If I do it, it's definitely, I see it all the time. But that's why another concept to understand as a clinician, I think, is that you can't draw conclusions based on your own clinical practice, because you do not have the ability to have that comparison to a control arm. That's why you need RCTs. That's the first step. Yeah, very interesting. We've got a few questions from the chat. Dali asked earlier on, I think that was during my talk, I saw that popping up, whether we had any studies that were using opioid antagonists to test placebo effects. And I think that's important again to say that the studies we were talking about didn't have the objective to study the placebo effect as a physiological phenomenon. It was really these are studies, evaluation, implementation studies that test whether something works better than these effects. And these placebo opioid antagonist studies are usually experiments where in an experimental setting, people are exposed to a placebo, and some would get an opioid antagonist to reduce to inhibit a certain response in the brainstem through which we think placebo effects work. That's one of the sort of key studies with which they found out that placebo analgesia, so pain relief from a placebo pill, for example, is mediated partly through those brainstem mechanisms. It's a very different research question and research approach to these clinical trials.
Totally.
Yeah, should we move on with some other questions?
So Dali's come in and said, so would you say that placebo effect is mediated by expectations? Or the other factors? It's a great question. So I think it probably is. I mean, expectations is a huge part of this. So if you have low expectations, your placebo effect is automatically lower, but it's not the only thing. You know, there's a whole raft of things which we've probably covered in both talks, which can also moderate and enhance the placebo effect. And the difficulty for me is that some treatments, so how to separate these out to a sort of a purely physical or physiological aspect and say that's the treatment. And some people like to do that sort of thing as clinicians, and other people say, oh, it's the whole treatment package. So and I haven't come up with a conclusion for that, really. You know, it's all about bedside manner, it's all about that sort of stuff. How much of those sorts of things help the person get better, and how much does that enhance your treatment? It's really hard to gauge that, and there's clearly some things which are not that important. You know, you take the bedside manner thing, for instance, and say you're in an emergency care situation, you have a rude doctor who knows what they're doing. It doesn't matter, you just get better and you have the right treatment. You have something which is a different sort of pathology, and it's really important how, you know, that decision-making process goes on and where you end up. So all those things are complicated. It's very three-dimensional. And, you know, we're just talking about placebo as a design here. You go into it in a little bit more detail because of the area that you're in therapeutically. But it's not straightforward. It's you know, once you get your teeth into it, you realize how three-dimensional the whole thing is. And healthcare. And as a hardcore trialist, I end up questioning, you know, should we even be doing trials? Should it be something else? But we just talked a whole lot about placebo-controlled trials.
Yeah. Yeah, it gets to the question of how do placebo effects interact with treatment effects. We randomized control trials assume, in addition, you have a placebo effect, and then anything on top is just added. But like you said, you know, what if the actual benefit, you only get that if you have a good relationship with your provider, and you can easily see that happen in clinical practice. If you don't believe what your clinician says, you might just not follow through with the treatment, or you might not believe in it. So there are non-linear interaction, complex interactions.
Yeah.
What do you think? Is that an okay simplification for clinical trials? Is that just the best we can do, what we have to do?
Yeah, I think it's entirely reasonable to take that position on it, and you know, we're getting more knowledge on it as time goes by, and I said it's not right for everything at all. So I'm mindful as well, trying to sort of force fit everything to pharmaceutical research as well, which is perhaps not the best way. That's great that they have got that, but it doesn't work all the time. So our designs and our models and things like that may have to be a little bit different for surgery, and that's the next phase, I think, and any complex intervention. So whether it be physio or, you know, psychiatry, CBD, whatever it is, anything which involves skill-based interactions or things which are not so single dimension or physiological, then we need a better and more clever way of evaluating them, I think. There's a good question from Adam there, and he says that is there a magnitude of improvement with placebo in general? As we've just discussed, I don't think there is actually. You can't say that you're always going to get this. There may be none at all. There may be some. It's pathology specific, it's person specific, it's domain specific. There's a whole bunch of stuff with that. So you probably, a bit like an MIC, you have to personalize it to your question. So I think, no, to say that there's a general improvement or magnitude, I wouldn't like to say that at all.
Yeah. There's an interesting from Ron here. Do you think such trials can be done in a small clinic with only a few staff, bearing in mind the dynamics of therapists in practice can influence outcomes? Yeah, I think especially surgery, obviously you need the sort of medical infrastructure around it. So they, I suppose, are, well, I don't know, in your orthopedic surgery, 1 or 2 people in the clinic, you could probably do that. In clinical practice, like manual-therapy, you at some point have to draw on what's called practice-based research networks, because it's just going to be hard to get certain numbers in academic settings. That comes with certainly different challenges, like monitoring what's actually going on during the trial. But probably is, and is also asking different questions again, thinking of that pragmatic spectrum that probably tells you more about how an intervention pans out in the real world rather than under ideal circumstances in your university hospital. Do you have anything to add to that, David?
No, I think that's really difficult comparing the different sorts of interventions and pathologies, really, because it's whether you're, I mean, the clinical trials world, as I already said, is all about averages and putting things together and summation and standardization. And actually, that doesn't work in some forms of therapy, where the last thing you want is standardization for it all. You actually want to look at the patient or the individual or the therapist or whatever it is as an individual and treat it in that way. And once you get that, when you start to summate things, you either need lots and lots of them, so that lot effect is lost, or you're going to accept that you've got, you know, sort of polar representation going on within the study. So it doesn't really work for certain things. So I would probably say that trials of the type that I'm talking about anyway probably can't be done with a single clinic or with like, I think there's research and evaluation that could be done within that, but probably in the types of studies I've talked about, you need several sites and greater representation. So it's more generalizable and externally valid.
Yeah. Just on the topic of individualization, the COP statement talks more about that clearly because many of those interventions live from being individualized, and the recommendation there is to standardize the extent of personalization or individualization. So you define your protocol, what's in and what's out of scope for the treatment and for the control intervention.
Yeah.
So you'd say, you know, if you also advise people on general lifestyle and mental health and their exercises at home, then do that in both arms, or don't do it at all, but make sure that at least these factors are balanced. And if you can, monitor that during the trial and take that into account. But clearly, just it adds another level of complexity and statistically heterogeneity.
Yeah. That's right. Maureen has come in with an interesting statement. And are there any trials as to how to maximize the placebo effect rather than to eliminate it? So we're not eliminating it, we're accepting it's there and accounting for it. So there's a definite difference in language and concept there. So we don't want to eliminate it. I mean, the surgeons would like to think that there isn't a big effect there and that what they do is the most important thing, or whoever the clinician is in the intervention. But I don't know of any studies that do that. And it brings in the thorny questions of, if you show that the placebo effect, or whatever it is much greater. I mean, in our seesaw, it didn't show it a great deal better, but imagine it flat-lined along the bottom with the no intervention at all. And okay, what you thought you were doing, you weren't doing. It doesn't really matter. You're doing a whole bunch of stuff which has benefit. Would we be willing to pay for that? So the Scandinavians are really interested in this. They do two-arm studies, and they say if the placebo effect and the real intervention, there's no difference between them, we should not look at the treatment and take it away. I'm not so sure about that, but I'm also not sure about paying for placebo treatment.
Yeah.
Excuse me. So yeah, it's a really good question, and I don't know of any. But you know,
I mean, there is work around more in the placebo world itself, where it's about figuring out what contributes to placebo effects, what influences the magnitude, and partly that interest largely comes from trying to minimize placebo effects in drug trials, because the smaller it is in drug trials, the larger your treatment effect. And certainly in the drug world, I've just been on a conference in Brussels, that really is still a big topic on how can you identify placebo responses, get rid of them, train people to report pain adequately to make it more reliable, and reduce placebo effects throughout, with the assumption that they might not be linearly interacting. So the more you can reduce it, the better. But in the sort of study of the placebo effect itself, you get things like open label placebo treatments, where they really put in a lot of effort to make a big, don't want to say show, but to produce a package that maximizes positive expectations as much as is ethical in some way. So certainly there are lots of factors that we think are influential, but again, I think the placebo world is more complex than they themselves like it to be, with not everything being as powerful as initially thought, including open label placebos potentially.
Agreed entirely. So maybe we should just take one more from Adam, just to finish. I don't think so. Last one on the list there, but and I don't know the answer to this fully, but so has placebo been proven for objective numerical changes? So we're talking about physiological changes, placebo, or is it just pain and mood? And it just yes is the answer, and I can't give you any specific quotations of that, but you will get physiological changes with the placebo effect, be it sort of examples of bilateral training, or in Seesaw, we looked at whether parts of your brain lit up for pain on an MRI scan or not. And even though that they hadn't had the surgery, their pain reduction, and it was a very physiological response. So you can change things with it. And the mechanism is elaborate and complex, but as human beings, we are. So you can't necessarily always separate them out. It just depends on what metric that you're looking at. So the answer is yes, you can change things physiologically for sure. And then it brings in the question is, if that's cheaper than doing something else, then should you do that as a healthcare delivery system under stress? Who knows?
Yeah, placebo effects certainly aren't imagined. They're not just in your head, as you would say. They have a physiological component. They might be less pronounced in what you call more harder objective outcomes like mortality, or I don't know, wound healing rates, or fracture healing, if that can be said. Yeah. Okay. I think let's wrap it up. Go for dinner. Thank you very much for taking the time, David, and all the attendees for being there, asking so interesting questions. Thank you very much.
Likewise, I'll thank them all as well, and thank you for your talk, and also Brexit for organising it, and the British Pain Society. Thank you very much indeed.
Yeah.